Well, thank you very much, Josh, for that introduction. Thank you to the Pioneer Institute for inviting me to participate in this great annual tradition. I suppose I should also thank the Obama administration for making this talk and my work necessary. It's sort of a lifetime annuity in criticizing the Affordable Care Act, one that I'm willing to retire and move on to better work, but it seems to be a constant call on that. You've got the basic title of tonight's lecture. Let me give you a slightly alternative one. Come up here. Okay. Or we're not in slideshow, maybe. There we go. Conjugating Obamacare. The past wasn't perfect. The present isn't simple. The future isn't progressive, but it will be tense. So much for the verbal part of your Common Core requirements tonight. Okay. Okay, this is a little sticky here. Maybe I'll get it figured out. Quick overview as to what I'm talking about tonight. Briefly, what happened, not too distant past, where we are at the moment, where we're going, the possibility of changing directions with a better GPS system, the forecast for the future ahead, definitely cloudy, but at least a slight chance of some rays of sunshine. How did we get here? Well, there was that brief perishable partisan supermajority in the District of Columbia back in 2008, 2009. That was when Yes We Can, before Yes We Can became Control-Alt-Delete. The law was passed, a hazardous course through the Congress, whatever it takes tactics, a lot of desperation moves, but it finally went there in March of 2010. Shortly after it was passed, I wrote an article in Health Affairs saying it was a temporary ceasefire in the first 100 years war. This has been going on in health policy reform since the Teddy Roosevelt administration at the beginning of the 20th century. As compared to the original first 100 years war in the 14th and 15th centuries, that was a little less bloody and less medieval than our healthcare struggles, and they actually came to an actual conclusion in that one in terms of getting the royal house in France. We had a lot of, after the law was passed, politically driven implementation. Again, whatever it takes in dodging and weaving. The promises that had been made in selling the law weren't quite the same as what could be delivered in the actual performance. So we had a lot of delays, detours, disguises. You got a different law than the one that they thought they were passing in Congress if they were thinking at all. Exceptions were the overall rule as to what was going on. Now, what was behind the political calculus of consent in the Affordable Care Act? Well, certainly in the early going, because it was going to take about 3-4 years to unload the major benefits or actually rewire the system, as we saw just this last fall and winter. So in the early stages, they had to deliver some early teaser benefits to say, look what we did for you right up front to get some early support. But it turned out that the architects of this law, we've seen this in administrations at an earlier time, they weren't exactly greeted by the natives as liberators. We had that slight problem with the Iraq War, as I recall, as well. The Affordable Care Act underwent a few near-death experiences, to be on the mild side. Most notable, the Supreme Court litigation decision in June of 2012. Even before that, the takeover of the House of Representatives by the Tea Party, aided by Republicans, and then the presidential race of 2012, and then, of course, the frozen experience of last fall with healthcare.gov and the Federal Exchange website. Now, what we've been reduced to in most of this debate is playing the numbers racket. How many are enrolled, whose premiums went up, which states are on board, who's setting up an exchange, all kind of the tedium of the horse race going on, but not necessarily looking at the bigger picture and defining success down or up as the case may be. But from the viewpoint of those who are backing the law, what they're mostly banking on more than anything else was not great success, but inevitability and inertia. If you leave a law around long enough, it gets embedded. It's very hard to tear it up from the roots. And so, in the words of that 19th century philosopher Friedrich Nietzsche, whatever does not kill me makes me stronger. That seemed to be the motto as many of these events went on at the ACA. We also had a lot of deal making with the health sector incumbents, both to pass the law and then keep them on board. They're really not the ones fighting against this anymore. the trade was, look, you're going to get all this extra business, expanded coverage, so maybe give us a little bit back. You know, cut back on the reimbursements, pay a few taxes, we'll call them rebates. It's reminiscent of a lesser character in Godfather 2, a local Don, who would basically terrorize the folks and say, I just want a little taste of the profits and I'll protect you. This was Don Fanucci, who just wanted to wet his beak. And that's basically, you have Washington wetting its beak off of the healthcare industry and doing quite well in the process in that type of trade. Where are we now? Well, we certainly have success in a limited sense of the enrollment, very limited terms. You can do the numbers. It's not, you can argue about it. I don't argue about who paid. Are they younger? But basically 8 million uninsured became insured by some calculations, and more will be in future years. What that means in the larger context of the healthcare system, that fades in the distance. There's also been a lot of excessive claiming of credit for the sun rising, crowing like a rooster, that healthcare spending has gone down. This started even before the Affordable Care Act was being marked up in Congress. We've had about 3 years of very low spending rates of growth in healthcare. The formula for that, of course, is take a recession and I'll call you back in the morning, you'll have lower health spending. We'll see, there's some early blips indicating that the spending rate is going back up. It'll naturally go up in this year anyway with the increased enrollment, but there may be a little bit of a sign of bouncing back from less of the economic lag of not only the recession, but a slow growth economy. Nevertheless, where we are is we're just taking time off the clock. The more this goes forward, the less more difficult it is to go backward or in a different direction. And then the full regulatory toolbox has not been unloaded, partly because they couldn't figure out how it worked, but also because they didn't want to kind of rattle the cages politically. Nevertheless, we've had a lot of disruptions of existing coverage where people lost the coverage they wanted or were promised they could keep, and a lot of shifting costs, both visible and invisible, not just from the old to the young and the unhealthy to the healthy, but all across the place, and depending on which state you're in and which market you're in. We've also seen a lot of expansion of Medicaid, not only Medicaid itself, but also Medicaid Light, as kind of plans close to Medicaid coverage in the exchange marketplaces, and a lot of state-level battles because a number of the states did not they took some exception to both either running their own exchanges or expanding Medicaid. So who would be some of the winners and losers in this? Well, certainly cable talk shows have had a great time, and I've benefited from that indirectly as well. It's a little uncertain as to whether the folks who want Medicaid for more are winners, or whether the skeptical holdouts in the states are going to be the winners. We'll see that as it evolves over time. And maybe the last healthcare sector vendors still standing. The Blues have done pretty well in maintaining their natural advantages in most of the individual and small group markets. Will private exchanges become a competitor to displace the public exchanges among large employers? That remains to be seen. Among the losers are the 3 Rs. Now, you've heard of the 3 Rs. They're supposed to be to bail out the industry with all the premium spikes, reinsurance, risk adjustment, and risk corridors. I'm talking about 3 other Rs that are big losers in the way this law was passed, the way it's been implemented. Reading, writing, and arithmetic. Nobody read the law when it was passed. It was written in a strange way that could be made into anything you wanted to, and they certainly didn't add up. The big winners, though, are the Amish. Think about it. They're exempt from the individual mandate. They shun the internet, don't use electricity. They didn't get bothered last fall. I'm not surprised there are not more people saying, don't bother me, I'm Amish, just go away. Excuse me a second, I just jumped ahead there, but I don't think I know how to go backwards, which is just as well, given what some accuse me of. There's been a lot of talk about, in the other part of the book of the ACA, health delivery reform. And so we're going to have what you might call managed innovation by the government. And of course, it's to come. It hasn't actually happened. There's a lot of pilot programs. And the earlier slide up there was the perfect vision of kind of the lead group being out there flying in precision like the Blue Angels. Tightly aerobatics, aerodynamics, and they just kind of, always hit precisely there. On the other hand, there's another version of some of these pilot programs. They don't quite hit the target. They run out of gas, and perhaps they come back where they started from. More like the USS Bunker Hill in World War II, a victim of a kamikaze attack. Sometimes the pilot gets a little short-circuited. But there's still the hope that perhaps we'll have a new type of regulatory-induced innovation, which is no matter how tight you make the maze and confused it is, somewhere out there in the private side of healthcare is going to figure out a way to make a profit. We don't know how, but it's kind of like, well, you know, you go figure it out. So it's somewhat like, let's see what I have here. Cannot locate the internet server at proxy target. Okay, well, I can't either, but they hit it there on the, okay. I'm having not a wardrobe malfunction, but a PowerPoint malfunction. Okay, well, I'm just going to go manual then. There it is. There must be a profit out there somewhere like pigs hunting for truffles in the French countryside is the basic model there. We'll do it differently this way. I'll just do it with the trajectory thing. We've got an evolving political landscape where we're not where we were, say, in 2010. You know, everybody worried about becoming bankrupt overnight. Oh, Europe will go first, we'll follow behind them. Those debt horrors have been received. Not that the debt isn't big and the budget deficit isn't big, but it's not as extreme as it was a few years back. Health spending in the same way, not growing at the rapid pace it was before. And the expectations game has been, we've lowered the expectations a lot from the advocates of the law. Whatever functions is good enough. On the other side of the expectations game is trying to hold people to standards that they can't meet anymore. We're seeing a lot of narrow networks, high cost sharing, Medicaid light in the exchange blitz. They're not quite what were promised to be the comprehensive, wonderful coverage that people thought they were going to get, because you can't afford it. That's the only way to keep the premiums down. A lot of it changes in the health industry, which means that they're basically now willing participants in the enterprise because they have nowhere else to go. A lot of embedded investments and expectations. And a different kind of political competition is also going on under the ACA. Not the idea of, you know, all the folks will come out there in the marketplace and the exchanges, but the idea that the only way to really survive in this environment is to become not quick and nimble and small, but big and fat and bloated. You got to bulk up in order to be the last survivor. So, you know, we've got acquisitions of doctor practices by hospitals mostly. Insurers not only bulking up, but also trying to shed their at-risk business by passing them off to other people. Pharmaceuticals, the big boys buying up the biotech innovators. So the idea is kind of everyone wants to be big, so they remain in the ring. And what we get is this form of competition, which is everybody trying to get leverage over the other one, and they're basically slow and all kind of fighting to a stalemate. Some political takeaways. What really came out of this experience is, contrary to the advocates and the proponents, is this tarnished the bigger government brand, the idea of one more step up the social insurance welfare state ladder, and can we sell you some other products along the way? It turned out that healthcare in particular is just too complex to delegate to the progressive version of the rule of experts. We've got the president and some of his congressional allies limping and quacking toward the next election season. There's been remarkable staying power for the opponents of this law. When you think about it, a law passed 4 years ago. Now, normally by that time, things are over and done and settled. You don't still have plurality and sometimes a majority of the people saying it's a bad idea. We don't like it. It's unusual that you have this type of major change in law passed by a total, partisan majority without any support from the other side. And this is still going on despite what would seem to be settled business. That's very unusual. You look back at Medicare, Medicaid, nothing on this scope. It says something about this law, how it was passed, the nature of it. It didn't go down well with the broader American public. And you only have one chance to make a bad first impression, and this the ACA did it last fall. We've got polling which now says, well, what about all this new success, all the people being covered, the website? People are saying, no, it's not working. I don't think it's very good. It really matters how what the impression you form coming out of the box. We're also, though, locking up all of the claims on our resources, both public and private, on younger and future generations, because here's basically the federal budget as you go forward. It's essentially with transfer payments, an ATM machine. Not much room for anything else, and this is just adding one more, not fully paid entitlement on top of the earlier ones we weren't paying for and couldn't keep solvent eventually. So the other message of this is the perils of political crossbreeding. The advocates of this law, they had to do a little bit of a straddle. They couldn't get what they wanted. They would probably like to have more of a single-payer-like government-centric, universal coverage mechanism, but they had to do it in the trappings of, well, it looks like the private folks are still somewhat in control, and we could say it's a little market-like. And so you get this kind of weird type of crossbreeding, which turned out to look like this. It's called a Zonkey. It's a crossbreeding of a zebra and a donkey. It's the new mascot of the Democratic Party. At least some of the border state Democrats or the Southern Democrats who are running for Senate for re-election, they may be able to try to change their stripes, as the case may be. Now, this type of crossbreeding happens in both political parties. It's not a pretty sight when it occurs. It's happened before. Enough said. Where are we now? Everybody pegs the meter and says, oh, it's the worst thing ever, we're going into the gulag, or we're just about to have that type of, real health care you wanted to have has been held back all these, a century or so. We're going neither toward apocalypse now, nor nirvana. First is, we got the bitter fruit of partisan health reform and a lot of tempered ambitions and limits to growth. It turns out our political system has its built-in regulator, whether you want to say in a Newtonian sense it's gravitational or centripetal forces. You get a little too far out ahead of everything and it tends to snap back in. And so I think we've already hit the ceiling on how far the law is going to go. I know people like to conjure up all the horror stories, it's going to get even worse. It'll be bad, but not in kind of the catastrophic sense. It's certainly the floor is that it's hard to withdraw, benefits to people once they've been given. You can weasel them away, but that's the history on that front. So we're going to muddle along with what we usually get in health policy: chronic bureaucratized mixed mediocrity. A good day's work in Washington, or perhaps several years. The legacy of Obamacare is essentially further politicization of health care, increased dependency, politically brokered health care. And I think the folks who designed this wanted that to happen, although it's kind of with a lot of overload on it. And one of the overload is on the public sector. We just can't do these things that well. Maybe in Europe, Uwe would say, well, they do this stuff very well. We don't do this government that well here. And so we've overloaded our public sector with a lot of commitments and demands and capabilities we don't really have. And in addition to that, we create a lot of deadweight losses when you run it through the tax system, when you run it through the political spending spin cycle. You get different things than what you started out with. So we squandered a lot of time, a lot of resources, and a lot of efforts. And there's been a lot of corrosive side effects on our politics. All this irregular extra-legal disorder, this improvisation of the rule of no one, which Phil Howard talks about at greater length in other contexts. We're just growing too accustomed to dysfunctional government. I mean, we've had it for a long time, but it really is kind of a bit too much. Now, back in 2009, 2010, there was a Tea Party. The peasants were revolting. They recoiled at this. And this was in the middle of the afternoon. They had torches and pitchforks. They were really mad. But are they disappointed now? Should they just give up? Well, here's my mascot and my hero. This is Hiroru Onoda. He actually died earlier this year. He's the last Japanese soldier to surrender in the Pacific Theater in World War II in the mid-1950s. He's out there in the Philippines, and his orders were, don't surrender, don't kill yourself. And he was just waiting till his commanding officer would tell him the war's over. Well, no commanding officer showed up. The House Republicans have the same problem. They can't find a commanding officer to listen to, so they're just continuing to fight there in the wilderness. Now, when they were going after this, the big mantra was, you heard a lot of repeal and a little bit of replace. Well, they're coming around to the idea that perhaps we need to reverse that order, and so a little less repeal and a little more replace. It's slow progress, but it's coming along on that front. So you got two basic strategic choices here. When you're facing an implacable foe that wants world domination, what do? Well, in the late 1940s, George Kennan had the theory of containment. He was a Princeton man, not at Princeton University, but lived a long time in Princeton, working at the Institute of Advanced Studies. And if you got an implacable foe, what you have to do is build up your own institutions, wait them out, strengthen yourself, and eventually it'll run out of gas. Although Kennan changed his views along the way from Mr. X and the long telegram. Now there's another view, of course, which was the counter view in the early 1950s. John Foster Dulles, rollback. We need liberation. We need to overturn that regime, and we're going to take him out. Well, he barked a little bit more than he actually carried out once he was in office, but those are the two polar cases. We're going to have to do a little bit of both. So some reality check lessons, though, before we attempt that on the Republican side. I'm disappointed in the folks that are there, but as I learned from a former Boston Celtics head coach, you got to play with the folks you have. Larry Bird's not coming through that door. Kevin McHale's not coming through that door. Robert Parrish is, and we got some young kids here. We got to go with them. Of course, he went on to Kentucky, as I recall. All right, so what's been the playbook? You know, we're going to root for failure and it's going to collapse on its own. We're just going to say no and it'll go away. Well, that didn't really work. Some simple fiscal formulas. We'll just cap everything and it'll kind of balance things out. And we'll toss everything to the states because we're holding the state houses anyway. And they'll figure it out even though we don't know what they're going to do. And we'll just give them less money and they'll do more with it. That's kind of the one-way Medicaid federalism approach. Or we can play the other Santa Claus, which is we don't like to spend money. Well, we do like to spend money. We just do the tax code. So we'll give you some tax breaks. So that's the Republican version of the alternative on that. This is not going to be enough to get the job done. So beyond the short-term, you know, delay and quick fixes, what do you do after the little delays to begin to turn this around? You got to fix things. You got to deregulate to some degree, rebalance as much as you can. What's vulnerable remains the individual mandate. No one likes it. No one's going to enforce it. You need to put it out of its misery and move on to something else. We're going to have to re-privatize, and they weren't that private to begin with, our political health care markets, and begin to take back some of the rubble and the layers been put on top of it, the stupid metal tiers. Let people buy whatever's a legal product. You can go ahead and subsidize it, but don't try to cross-regulate and subsidize all that type of stuff. Scale back the subsidies at 400% of federal poverty level to a lower amount to people who actually need it more so. Level the playing field for all the plans and try to do that for the tax subsidies too. Give the states some flexibility, but ask them to be accountable for better health outcomes in return for that, not just a one-sided trade to play around with someone else's money. And by the way, elections matter too, as opposed to just screaming and howling into madness. There's a lot of attention deficit disorder when it comes to this type of policy reform. These are the basics they've talked about, but they don't carry through on it. You need a real safety net. You can't finesse that away, but you need to retarget it for need. It's gotten a little bloated and misdirected. Continuous coverage incentives are the main alternative, both the pre-ex conditions and the individual mandate. Start playing seriously with health sector delivery reform as opposed to just passing it off like my doctor's fine. What do we have to do about it? The private sector will solve everything. We need better information infrastructure for decision makers. The Obama administration has been better on that than most of the Republicans have in terms of at least getting some Medicare data out, and more entry and exit without cronyism. Now, the biggest problem in health policy is its astronomy. The experts in health policy go, look at this, go, everything is revolving around me. It's Ptolemy all over again. Everything, circles around the healthcare sector and feeds it and takes care of it. It turns out you're not the center of the universe, although you act like it. So if we get to a little bit more of a Copernican idea of the larger world in which we live, which health is a part, but not the only part, we begin to redirect our astronomy of healthcare. This is what's incomplete in the bigger picture. We need to expand the toolbox in the portfolio than what we've been talking about in most of our political discourse beyond health insurance. Put it in context, we've got to reverse the dependency ratio. If too many people are depending upon the people who are producing and working, I'm not talking about 1% and all that nonsense, that's stupid, but we need to build people up. They need jobs, they need incomes, they need intact neighborhoods and families in the future, and resources to build health and human capital. That's what we need to focus on, as opposed to thinking, how can we put someone else on a temporary political dependency for perhaps a long period of time? We have to improve health outside the doctor's office. There are a lot of other tools to work at in that regard than just seeing a doctor and having a health insurance card. We don't think about that enough and creatively. So let's remember this. It's a marathon, not a sprint, despite the way in which I presented this talk. Thank you.